Hi, everyone. Welcome back to Clinician's Brief, the podcast, where we bring you the conversations behind the content. Today, I am so excited to welcome Dr. Alyssa Jenkins. She's currently completing her residency in small animal internal medicine at Texas A&M, and she co-authored a Clinician's Brief article last year that highlighted the top 3 advances in feline diabetes management. And so she's sitting down with us today so that we can talk a little bit about, what's changed recently for clinicians, cats, and for our clients when we're managing these diabetes cases. Hi, Dr. Jenkins. How are you doing today?
Hi, I'm doing well. Happy to be here.
Good. Before we dive into all of these questions, and I realize I have just a list of diabetes and endocrine questions to ask you today, I was hoping that you might just introduce yourself to our audience, tell us about your background, and how you ended up at Texas A&M.
Yeah. Well, I'm Dr. Alyssa Jenkins, as already discussed. I'm a Michigan native, so grew up there, went to undergrad there, and then I hopped across the lake to at the University of Wisconsin-Madison for my veterinary training. And then since then, I've slowly meandered my way south, somewhat inadvertently, but have gotten away from the snow, which has been a bonus. So I did my internship at Tennessee, and then I stayed on for a year as a clinical instructor in emergency and critical care. So also have a passion for those slightly more sick and urgent cases. And then started my residency at Texas A&M, which has a program that has been a great fit for me.
That's wonderful. I went to Iowa State University, and so yes, after I graduated, I also migrated away from the snow, and now I practice and live in Las Vegas, and so we don't get to see that snow anymore, which I'm totally fine with.
Yes.
So, diabetes mellitus. This is a super common endocrinopathy. It is probably one of the most common ones that I see, especially in cats in practice. Do we know what the prevalence is of diabetes in the general cat population in North America?
Yeah, so our prevalence data is a little bit dated at this point, actually, where the last retrospective was, I think, pre 2000. But we usually estimate between 0.2 and 2% in North America, with about 95 million cats in the US. A pretty good point of reference, like comparing that to something like hyperthyroidism, which we also see a ton of, is estimated about 10% prevalence. So less common, but still quite a lot in the scheme of the cats that are going to enter our care.
Yep. And then, when I'm explaining this disease to clients, most clients are familiar with diabetes, because it is a prevalent disease in humans as well. Why is diabetes considered more similar to type 2 diabetes in humans than type 1 when we're talking about cats?
Yeah, I think this is a great point of reference for owners because, as you said, a lot of them are familiar with the condition in general, but maybe not the type of presentation that we're seeing depending on their experience. So, type 1 diabetes, or diabetes mellitus specifically, is going to be a complete loss of insulin producing ability. So, those patients, whether human or animal, have an insulin deficiency, which means that they become entirely reliant on exogenous or external insulin sources. The body just can't produce enough to maintain normal physiology. And type 2 diabetes mellitus is a little bit more complex in the sense that it often starts with other factors that create insulin resistance. So that can be exacerbated by things like being overweight, having a high carbohydrate diet, a sedentary lifestyle. But that cat can still make insulin. It's just not as receptive to it, or its body cells aren't as responsive to it. So those cats that go on to develop diabetes have a reduced ability to compensate for this insulin demand, and their decreased ability to secrete more insulin eventually becomes impaired as well, as their body tries and tries, and that hyperglycemic status can create inflammation and injury to whatever remaining functional pancreatic cells they have left. And then you get this chronic cycle of and elevated blood sugar and toxicity to those cells. And it all just kind of perpetuates this diabetic state and leading them to become insulin deficient ultimately. So kind of starts one way and then ends another that's maybe a little bit more similar to type 1 diabetes. So similar to people, these guys can also benefit from early changes in lifestyle and helping to mitigate some of those things that make them insulin resistant to help reverse that process and prevent that beta cell destruction long term.
Also, another thing that I find challenging is, we think of diagnosing diabetes with, hyperglycemia accompanied by glucosuria. But cats in particular can get really stressed, especially when they come into the clinic. And then I do find that it can be difficult. Are we dealing with a stress response, or is this truly diabetes in some of these cats? So, what other kind of evidence or clinical signs do you think is necessary to really support this diagnosis of diabetes in cats?
Yeah, that's a great question because you're right. Like most of us small animal practitioners are going to see cats in the clinic that are hyperglycemic and potentially have glucose in that urine that aren't in fact diabetic. So exactly, it's how do you parse that out? But we know that the renal threshold for glucose is somewhere between 250 and 280 mg per deciliter. A stressed cat can certainly exceed that, as will a diabetic friend. So it's important to utilize their clinical history for these cases, like questioning the owner thoroughly, like are they polyphagic? Are they polydipsic? Are they seeing more trips to the litter box? Are they seeing weight loss despite a good appetite? And then another test that we'll often recommend for confirmation is a fructosamine, which is just another blood test. And that value is not going to be super impacted by a single stressful event or even a couple of stressful events, and gives you roughly an average of what their control has looked like or what their blood sugar has looked like over the preceding 2-ish weeks. And then when in doubt, there is an ALIVE group, which stands for Agreeing Language in Veterinary Endocrinology, and they have some published criteria to reference to for really getting those patients that qualify as being truly diabetic. But I think fructosamine is an accessible adjunctive diagnostic that most of our small animal practitioners are going to have access to.
That's a really good pearl. Thanks. Let's jump right into one of these first advancements. And I'm going to preface this by saying I have not used any of these particular drugs in practice yet. So I'm really only in clinic a few times a month these days. But let's talk about these sodium glucose co-transporter 2 inhibitors. First of all, what does this protein do for glucose regulation? Where in the body, does it act? Tell us a little bit about this protein.
Yes, these are so fun, and it is such a mouthful. So we're gonna say SGLT2 for the remainder here. But these are really fun to talk about, and understanding like what they actually are and how your drug is actually working, I think, is really important for understanding how to use them properly. So it's a little bit easier with a picture visual, but I'm going to do my best in words here to explain. Essentially, there are two different types of SGLT proteins in the proximal renal tubule. So 1 and 2, 2 being our target with these drugs. So normally, the first protein that the urinary filtrate is going to encounter in that proximal renal tubule is your SGLT2 proteins. And normally, they're responsible for about 90% of glucose resorption by the kidney. And then your SGLT1 takes care of that remaining 10% or so. But when you use an SGLT2 inhibitor, you knock out that roughly 90% of glucose resorption, and then all of that glucose is subsequently lost in the urine instead. But you don't get hypoglycemic because you still have your SGLT1 to help compensate for some of that. So that continues to function, resorbing some glucose and prevents you from getting into an urgent state.
And then it's important to do some screening tests for these cats before we prescribe one of these. So can you talk a little bit about what screening tests we need to be performing and why they are so important when we have a newly diagnosed diabetic cat?
Yeah, absolutely. So I think the biggest thing to remember when you're approaching these cases and screening one of these cases and thinking about this drug class is that you want to make sure or feel reasonably confident that your patient still has some insulin producing ability, because the insulin is what you really need to drive that glucose into cells for energy and ultimately to avoid ketosis. And your SGLT2 inhibitors don't do anything to help with that. So if they don't have some degree of insulin producing ability still, or they're experiencing another illness that's going to increase their insulin demands beyond what remaining little function they have to produce insulin, then they're likely going to become progressively ketotic on an SGLT2 inhibitor, because those drugs aren't going to do anything to stimulate glucose uptake into the cells. So we typically don't recommend them in patients that have significant renal or hepatic impairment, since that can affect drug metabolism and action. So thinking about all of that, your screening is typically going to be a minimum database, meaning a complete blood count, chemistry, a urinalysis, just looking for other conditions that are maybe going to change their insulin need concurrently. And then ideally screening for any other disease that might be present, like hyperthyroidism or clinical pancreatitis, or some of those more common things that like to crop up concurrently with diabetes. And then your big important one is going to be a serum ketone concentration, which is accessible via handheld monitor to a lot of people. And even sometimes we'll have owners purchase those for home use. So they're very easy to use, and some of them have been validated in our feline patients. And then your SGLT2 inhibitors are generally going to be a good choice for your newly diagnosed diabetic cats. So assuming that systemically things check out and they seem like an overall healthy cat otherwise, aside from the diabetes, and they're not significantly ketotic, they don't have evidence of obvious organ function impairment, and they're eating reliably, I think is the other big one to consider, then they're probably a good candidate. And then we also mentioned like diarrhea is a fairly common side effect with the SGLT2 inhibitors. So if you have a patient that already has chronic diarrhea as a component of their background, maybe not the best choice for those kiddos.
Yeah, that's a good point. I hadn't heard that before, actually. I know there can be sometimes risks of prescribing these in cats with who have previously been treated with insulin. Is that because, like we said, these drugs really don't do anything to help glucose get into the cells, into the body?
Yeah. So that's definitely an important factor for these guys. So we think the longer a cat is on insulin following diagnosis, the higher that likelihood becomes that that cat is truly insulin dependent, meaning that they need that insulin that we're providing them and aren't making enough on their own for us to safely use an SGLT2 inhibitor or to rely on that drug class. In the trial with one of these SGLT2 inhibitors that's now on the market, cats previously treated with insulin were put on this medication for the purposes of the trial, but they did find a higher rate of euglycemic diabetic ketoacidosis development than in those cats that had never seen insulin. So we do have a little bit of data to suggest that that's going to be a bigger concern for these kiddos. We do think realistically that there's probably a little bit of wiggle room for those patients that have been on insulin for a brief period of time. Anecdotally, we think less than a month is about what we're saying. Beyond that, I probably wouldn't try. But if, for example, you have a cat that's diagnosed with diabetes, say at an ER clinic or elsewhere, or the owners trial insulin and decide they can't manage it, it's likely safe to try them on an SGLT2 if they're not significantly ketotic. So I think that is an option for very specific cases, but definitely
Right.
some cases where that's reasonable.
And then the ones that I have seen are labeled for once daily administration. Do we have any evidence to support like more frequent dosing if we do have a patient where their blood glucose is remaining elevated, or they're still having those clinical signs of polyuria, polydipsia, but otherwise seem healthy? Like you said, they're not ketotic, they don't have other signs of illness.
Yeah, that's a good question, and I think there are plenty of medications where we think more is better or is going to increase efficacy, right? So super reasonable question to ask. But these guys, like realistically, the dose that's been developed is the dose that's suspected to cause maximum effect, or that seems to cause maximum effect. So at this point, we don't think that giving more is necessarily going to increase the amount of response that you see. So at this point, I don't think so. And the label doses do seem to work quickly, and they also seem to produce a sustained glucose reduction in the blood. Obviously, lots of glucose coming out in the urine, but increasing frequency doesn't seem to be required for those guys. And in some cases where we take them away, we will see residual effects for a couple days afterwards, also supporting that it probably sticks around for a little while. So not necessarily something where increasing frequency is going to increase efficacy.
Good to know. Now, when we prescribe these, when are we looking to get these cats back in the clinic to recheck them? And what should owners be looking at home? What specific markers do we need to evaluate when we get them back in?
Yes, all good things to know for these guys. And I will say that the labels for both of the available products are pretty helpful in guiding some of these follow-up recommendations. But usually we recommend the first clinic visit happen ideally 2 to 3 days after starting the drug. So, let them have the weekend at home and then get them back in. But specifically assessing ketone concentration, specifically beta hydroxybutyrate is kind of our best option to ensure that those ketones aren't increasing from diagnosis, because we want to make sure that that cat is tolerating therapy and that they have enough endogenous insulin, that they're not going to get ketotic on their SGLT2 inhibitor. And then if the ketones are not present at that first recheck, or if they've decreased since your initial diagnosis, then we usually check them again about 1 to 2 weeks after the beginning of therapy. And at that point, you want to do an exam, a body weight to make sure it's either stable or increasing, that we're getting some improvement in their diabetic signs. A ketone concentration, again, ideally blood, because that's going to be a little bit more sensitive than urine, and then a spot blood glucose to make sure they don't look hypoglycemic. And then with one of them, the manufacturer recommends either urine or blood ketone checks. We, like I said, prefer blood ketones because those are going to be recommended by most endocrinologists at this point, just because little fluctuations can have large clinical significance, and we want to be catching those sooner rather than later.
And then long term, how often are these cats coming back in? Similar to, cats on insulin?
Yeah, that's a good question. And I think depends a little bit on the patient, as with cats on insulin. But most patients, the drugs work pretty quickly. So most patients are going to have a well-controlled glucose if they're going to respond adequately within the first 2 weeks. So if those animals have increasing ketones or they're still hyperglycemic by about day 30 of treatment, then we consider them non-responders and typically recommend that they be transitioned to an insulin plan at that point. And then it's just kind of your standard diabetic follow-up and monitoring. Those animals that resolve or don't become ketotic at any point and have an acceptable glucose, and tolerate the drug well, so no horrible diarrhea at home, those guys can be moved to like a 90-day monitoring plan, so it can be certainly a little bit less frequent. We still recommend exam, body weight, spot check glucose while they're in the hospital, and a ketone assessment at each of those check-ins. And then also, I think just educating owners is big for these too, similar to like with insulin use, where we coach them on signs of hypoglycemia. For these guys, we want to coach them on signs of euglycemic diabetic ketoacidosis, and basically just have them catching any signs of illness early on. And this is an area where it's excellent if you can train owners to check ketones at home, similar to what you would do with like a blood glucose monitor. So they can purchase handhelds on like Amazon or online. They're pretty cost effective and can be trained to use those. So I think that is a great option for home monitoring in case concerns do arise when the clinic's not open.
You mentioned that most cats respond really quickly, and if by that kind of 1 month mark we're not seeing the response we want, then we need to think about more traditional insulin therapy. What does that look like? How do we transition? Do we need a washout period with these medicines?
Yeah, that's a really great and practical question. And the answer is that no washout period needed. You can actually stop them. The manufacturer, in fact, recommends stopping if signs of illness arise. And then if you're just switching from an SGLT2 inhibitor to insulin in an otherwise healthy cat, yeah, no tapering concerns. If you need to stop because the cat has become ill, like they say they've developed hepatic disease or have had an AKI or something like that, there is the chance chance that your SGLT2 inhibitor is going to stick around in their system a little bit longer. So you may see some effects beyond your discontinuation. So that's going to be something where you do want them on insulin because you're worried that they have increased demand and are going to need a little extra help to get over that illness, but you may need to keep them in clinic for blood glucose monitoring, because if you add insulin on top of that in a cat that's not eliminating their SGLT2 inhibitor correctly, then you're going to have an increased chance of hypoglycemia as you start to treat them. So that might be a good candidate for referral to a 24-hour center.
And then final question on SGLT2 inhibitors before we move on to another topic. And that is cats with acromegaly. Because, we talked about how cats with other disease processes, probably aren't the best candidates for these medications. And acromegaly is one that we sometimes see with diabetes, but can be a little bit harder to parse out.
Yes, these guys can be so frustrating to manage. I think that's a great question, and one that we will hopefully have more answers for soon. Currently, we don't have a lot of published data. Anecdotally, I think people are starting to use them in the management of acromegalic cats, as these guys do tend to have some residual pancreatic function. So in that sense, they're good candidates, but they're often on very high doses of insulin or have been diagnosed as diabetic because their blood sugar is extremely high, and their doses are very high because they're also extremely insulin resistant. And then when you add an SGLT2 to that, then you significantly increase your chances of causing hypoglycemia and going too far in the other direction. So I think these sorts of off-label uses are probably ones that we're going to start using more in the specialist community, and hopefully we'll have some better information soon.
Are you on track to hit your CE goals? Clinician's Brief has more than 60 hours of practical, race-approved CE, perfect for catching you up and keeping you up on requirements. Whether you prefer to read, watch, or listen, Clinician's Brief CE is on demand and always affordable. Start earning CE today at cliniciansbrief.com/CE. Okay, let's move on to insulins. We're going to talk about some of these newer, ultra long acting insulins. So we're talking about insulin glargine U300, insulin degludec. These insulins in people seem to last 30 to 46 hours. Do we know how long they typically last in cats?
Yeah. So we do have some data on both of these types. I will say it's a little bit limited, but growing all the time as far as our research. And I think we were all really excited about the potential for once a day insulin dosing, or maybe even less when we started studying these. Unfortunately, we joke that cats are aliens all the time as a veterinary community, right? But for these guys, for U300, they do unfortunately have a much shorter duration of action. So anywhere from 12 to 22 hours, depending on your cat and your scenario, and the study that you look at and all of that. So it can be pretty variable, but insulin, glargine U300 is going to be the most likely candidate for considering once daily dosing in cats, whereas the degludec is more like 7 to 13 hours based on the studies that we have. So we have data to suggest it might be a good once a day candidate in dogs, but not so much in the cats. They tend to burn through it a little bit more quickly.
So it looks like even these ultra long acting insulins, we might be having to dose a couple times a day.
Yeah, unfortunately, I think for a lot of cats, that's the case. Glargine U300, reasonable to try once a day at first, but may end up needing to escalate to twice a day.
Well, what about any other benefits? Something like, does the timing of these insulins relative to when we're feeding the cat, or if we have a cat that free feeds, is that someplace where we might see some benefit from these insulins?
Yeah, I think that's a really fun area, or a fun aspect of these insulins, is that theoretically it doesn't matter quite so much what their meal feeding schedule looks like, because these insulins are more similar to what we call a basal insulin, meaning that you should see less day-to-day variability. And we still recommend owners maintain a consistent feeding schedule and gauge interest in food before giving their insulin, so that they're not causing their pet to become hypoglycemic if there is a blip, or not missing illness if there is a blip in appetite. state. But the glargine U300 and degludec both have less reliance on being given at meal times than kind of our traditional insulin therapies. We do still see some animals that will have a more significant like postprandial hyperglycemia that overwhelms the action of these insulins. So you will still occasionally see some of that throwing off patients' glycemic control. And those candidates sometimes need addition of an intermediate acting insulin as well. So it's not perfect. It's not a one size fits all, but theoretically, yes, not as big of a deal that they be fed on the strict Q12 schedule.
And then I think a lot of clinicians now are really familiar with glargine U100. So when we're talking about insulin glargine U300, how do those two insulins compare? Like, what are their main differences? Is it just that the one is 3 times as concentrated as the other?
Yeah, that's a good question and like a really natural inference, I think.
Right.
And I think it's inherently confusing given how similar the names are. So biochemically, like they're both glargine. They're both, you know, more or less the same in that sense. However, the action is actually pretty different. Like the pharmacodynamic behavior is quite different between the two. So glargine U100 or our typical glargine or a traditional glargine that we think of as an intermediate acting insulin for which the timing of the nadir is going to be pretty predictable. We've had that one around for a while. Whereas with glargine U300 being a basal insulin, or sometimes we refer to it as a peakless insulin, its effects tend to be pretty similar throughout its duration of action. So instead of getting that set nadir, you're going to see a much more kind of sustained response and not necessarily the same peaks and valleys that you see with U100.
And then how do you figure out the dosing of it then? Is it there's standardized dosing of where to start those cats on the U-glargine or the glargine U300?
Yeah, I would say we're still working on that. There are suggested doses, and there are a couple papers that have published starting points where usually our inclination is to start them off a little bit lower on U300 than we would on U100, and kind of see how they handle that. And as a preview to one of our later topics, I think use of continuous glucose monitoring systems is really helpful with these newer ones.
All right, we'll circle back to that then a little bit later. um, so I have kind of the same question that we had, with the other drugs that we discussed earlier. Once we start these, when should we get when should we get these patients back in the clinic? And what are we looking for? Same things again?
Yeah, yeah. So these guys, you can think of it honestly pretty similar to any other like insulin administration and check-in. So approach varies a little bit with your clinician preference and your comfort with these therapies. A lot of times we'll recommend placing a glucose monitor sensor on day one of therapy on one of these newer insulin types, which sometimes allows us to optimize dose a little bit more rapidly, helps us detect hypoglycemia earlier, and then decide if the patient can maybe get away with only getting this once a day, or if they are one of those patients that really needs twice daily administration based on how long it looks like that's active. And like with any other insulin, helpful to educate owners on signs to watch for and what to do if they look hypoglycemic at home or if their diabetic signs relapse, and then placing a curve accordingly. So in most cases, like monitoring clinical signs is going to be really helpful for that first period, like that first week or so. And then when in doubt, the AHA diabetes management guidelines are a great reference for what to do at that first recheck, when to time that. And they're in the process of being updated to include some of these new insulin types that we're starting to use more.
One of the things when, people really started using glargine U100 for the first time was the remission rates in cats seem to be a lot higher than with using other insulins. And so is this something that we're seeing with the ultra long acting insulins as well? Are these cats achieving diabetic remission more frequently?
Yeah, So data's pretty new here, but there was a fairly recent small study looking at glargine U300 in cats that found about half of them went into remission. It's about 44%. But also important to recognize that not all of those cats were newly diagnosed diabetics either. So all of those that went into remission of the included cats were newly diagnosed. So about 80% of those new diagnosis cases went into remission on glargine U300, which is very comparable to our rates for glargine U100. So I think, at least based on that small little pool of cats, reasonable to think that our remission rates are similar to glargine U100.
All right. And you already mentioned that, when we start these insulins, it's a great idea to start using one of these continuous glucose monitors. This is just a huge, wonderful advancement, I think, for clinicians, for the cats, for owners at home. Although we will talk about that too. I have had some owners that become really fixated on these
Yes.
numbers. And so that can be difficult to manage that aspect of it. But first off, let's just start a little bit about, what are the key benefits of these monitors compared to like just our traditional glucometer based curve where we either at home or in the clinic, either one.
Yeah, yeah, I think I agree. These are great, but we certainly do have some of a continuous glucose monitor dependence that arises sometimes. But yes, I think they're hugely convenient. Like it can be applied one time and then you don't need to do any other needle pokes. There's no other sticks. So I think from that perspective, great for human animal bond and maintaining relationship with the owner and them not having to cause any sort of pain to their patient to obtain samples and thus minimizing stress. So on that, you also get a lot less stress interference. It's minimally invasive sample collection. They just have to casually walk by and scan their pet while they've got the sensor on, which is a lot less traumatic, I think, than trying to get a blood glucose and catch them and find them wherever they are in the home. And then you also get the advantage, like as opposed to a a clinic glucose curve, like you have them outside of their home environment and their schedule's inherently disrupted and their dietary intake's probably going to be different than it is day to day. Whereas with these continuous glucose monitors, we're getting a rough picture of what their actual day to day looks like because we're able to measure them in real time remotely, which is incredible. And you get a longer sampling period. So instead of just getting your, 12 hours that the clinic's open and those readings, like you can get up to 15 days now, sometimes with these newer sensor generations that are coming out. So you can assess trends over a period of weeks. You can make some dose adjustments sooner and sometimes even from the convenience of the office without the owner having to bring the pet in physically. So I certainly have owners that I email a couple times a week and we talk about what to do with the insulin. And then I can see how things go at home based on the changes that we make. So I think just lots of gains in convenience and also overall impact on the patient.
A lot less stress.
Yeah.
Do we need a prescription for these? Can anybody just go buy one?
That's a great question. At this point, yes, they are a prescription item, although they are available at most human pharmacies. So always good to confirm stock if you're going to recommend putting these on a patient and you don't necessarily stock them in your clinic, but readily available, still a prescription item.
Yeah. So most of my clients, we'll give a prescription, they will go to the pharmacy, purchase it, and then bring it in and have our staff, apply it, attach it to the patient. This it sometimes proves a little tricky. I've had them fall off, which is frustrating. When you want that 2 weeks of data, like you're talking about, and in 2 days your kitty gets it off. So, any tips or techniques for ensuring these stay in place?
Yes, this is a great question because we certainly have some particularly clever patients that are more determined to get them off than others, and many of them seem unbothered, but you occasionally get the one that is a real Houdini. So usually we recommend shaving that hair at the site that you're planning to apply really thoroughly, usually the like interscapular region or like over the shoulders tends to work pretty well. And then people kind of vary in their recommendation, but you can clean skin oils away with an alcohol wipe. You just want to make sure that you allow that to dry thoroughly. Otherwise, your alcohol is going to interfere with the adhesive on your Libre sensor or continuous glucose monitor sensor. Libre just happens to be the most common one. And then we will often reinforce the adhesive with tissue glue. I'll usually recommend doing like 4 dots around the perimeter. You don't necessarily want to coat it because you want it to come off when it stops working and without causing trauma to the patient. But I think a little extra help helps it stay adhered. And then just making sure you let it sit on the skin for usually at least 30 seconds after you've deployed the sensor to allow that adhesive or that tissue glue to cure a little bit. And then I'll often peel it away slowly, or maybe use hemostats sometimes to help it out of the application device or the applicator. And then some patients who are especially creative also benefit from having a covering, and that can be like a t-shirt, a thunder shirt, a little like Tegaderm or similar adhesive pad. So those can be good options too.
Yep, there's lots of little cat suits and things that are available online as well.
Yes, I think it's knowing your patient and what's going to stress them out versus what's going to keep the sensor on effectively.
I wondered a little bit about any scenarios or diagnostic procedures that we should remove these things for. Like, is it okay to take a radiograph of a cat with a sensor on? Is it okay for that cat to go, to have an MRI? What if the owner wants to bathe them?
Yeah, super practical questions and ones that owners will ask you. So definitely ideal for those sensors to be removed for diagnostic imaging. Like on x-rays, you are going to see it. It's going to show up. It's going to summate with whatever the underlying tissues are. So you're not going to be able to interpret that area necessarily. Granted, if you're doing a limb rad, do you have to take it off? No, don't worry about it. It's not going to cause any issue short of artifact. However, with MRI, you want to take those guys off. And then on CT, you will get some regional distortion too. So we will take them off for our patients going through the CT scanner and then put them back on afterwards. And then the more modern sensors regarding the bathing question do tend to be water resistant, which is great. I still recommend people not submerge them, but it's yes, as long as it is not a super intense bath, usually okay for them to get a little bit of water exposure. It's okay for them to go out in the rain, like that shouldn't pose an issue.
And probably a little bit less significant for kitties than maybe in our dog patients that would like go jump in the pool or something. My cat doesn't jump in the pool, so. I think one thing that it's worth bringing up and just talking about again is that these monitors, they don't monitor blood glucose. They're monitoring interstitial fluid glucose. So how do those readings correlate? How well do they correlate, and when should we be a little bit suspicious of our readings?
Yeah. So overall, correlation is pretty good in both our dog and cat patients. There have been studies examining that because it's a pretty intuitive question to want to know the answer to before you use one of these. We do see that the interstitial glucose does tend to lag behind a little bit by about 15 minutes relative to the blood glucose. So it's not quite real-time reflective, but it's very close realistically. And then they're also calibrated for people. It's a device developed for humans, so not necessarily calibrated to our veterinary patients like some of our glucometers are going to be, meaning that it's not uncommon for them to read out a little bit lower than our patient's true blood glucose. Usually we think of it being a difference of like 15 to 20 milligrams per deciliter, so it's not huge, but it's there. And then most of the time we're using them to evaluate trends, or like our glycemic trends. So if you do get an odd reading, or the owner gets an odd reading at home, I think it's still good to counsel them that it may not be an exact representation of where their patient is at. And that's a good point where if they are an owner that wants that peace of mind, training them to use a home glucometer, I think is super reasonable for some of those weird readings, just to make sure that that's accurate. The newest generation of sensors, we don't have any published data for in our veterinary patients yet. Historically, we've seen correlation decline with hypoglycemia. Like with a low normal blood glucose, the sensor tends to underestimate a little bit. But once you get into true hypoglycemia, like less than 60 milligrams per deciliter, it tends to overestimate, which is not really what you want at that time. So remains important to have owners be familiar with what signs of hypoglycemia are and what that looks like, and not to panic or not to initiate treatment on the basis of a number alone.
Yeah, absolutely. Always good to remember to reinforce to look at the whole patient, not just the number that your machine is spitting out at you.
Exactly.
Um, Finally, these do, like we said, we apply them, we get, sometimes as much as a couple weeks worth of data, and then we remove them. So, what do we do with them when we remove them? Like, how do we dispose of them? Is this something that's regulated? Are there any environmental considerations that we need to be aware of with these monitors?
Yeah, that's a good question. So the applicator bit we dispose of as sharps, like when we put it on in the clinic, because there's an actual little stylet in there. The sensors themselves don't have that concern. Like it's just a soft little flexible tip that goes into the interstitial space, so you don't have to worry about that. The manufacturer does typically recommend disposing of them like a battery, so seeing what's appropriate in your region for that. But thinking of them kind of like electrical waste is reasonable, and in some areas that just means tossing them in the garbage. So usually not a huge concern. Not to my knowledge, there are not currently any recycling programs, but I do know the biggest manufacturer of these has been working on making sensors smaller and applicators less bulky and trying to do some things to reduce the material use associated with these.
Well, that was good. That was all my questions. Definitely, we have a lot to look forward to, but I think, when we're talking about recent advances, that's going to be a theme here, is that we're still gathering data and a lot of this is going to change, but it's also really exciting. And I'm really glad that you were able to come in today and kind of get us all up to speed on what's been going on recently, because it seems like it's been a lot for cats in the last couple of years.
Yes, and cats are just historically so challenging, so it's definitely an area of active investigation to make this a little bit easier on owners and make it more feasible for our patients.
Yeah. That was all my clinical questions. I know that you co-authored this article with Dr. Bugbee, who's actually been on our podcast before. So I don't know if he tipped you off and warned you about our rapid fire questions at the end of the episode. But at the end of the episode, we do play a little just fun would you rather game. And I was wondering if you would want to play with us.
Sure, let's do it.
All right. Would you rather spay an obese dog or extract a carnassial tooth with a slab fracture?
Ooh, tooth extraction for sure.
Really?
Yeah,
Oh
I
my
think
gosh.
so. Then my surgical days are behind me.
Oh, I don't do teeth. I will take the fat dog any day. Would you rather write an international health certificate to Australia or do your own taxes?
Own taxes for sure.
Health certificates. Would you rather have someone in the clinic say, wow, that vein is huge, or gee, it's been really quiet today?
Oh, definitely comment on the vein. No, we don't talk about how quiet it is.
We're very superstitious. Would you rather work in an alternate universe where animals were all miniature sized or where they were all like gigantic size, like the size of T-Rexes?
Oh, definitely miniature. I used
Little?
to, yes, I used to dabble in wildlife and all those teeny tiny little songbirds. They're so fun, like so
Okay.
handleable. Yes.
That's great. That's great. All right, final question. If you had to pick one, would you rather have a TikTok famous dog as a patient or would you rather have a famous actor as a client?
Ooh, man. I think famous actor is a client.
All right. Excellent. Do you have an actor in mind or?
Oh,
Because for me, it's Ryan Reynolds.
I don't know. Tom Holland seems like he's probably nice. I feel like he'd be a good client.
I feel like he'd be a good client too. He is very nice. He is very nice. And his accent is great. Like when he's not doing his American accent, like his true accent.
Yes.
So every time I hear him speak really, like not in the movies, I'm just blown away. Well, that was it. That was all of my would you rather questions. I hope it wasn't too stressful.
No, those are low stress. Easier than I expected too.
Excellent. Excellent. All right. Well, thank you again for joining us. Thank you so much to our audience for listening, and be sure to tune in next time and we'll have some more conversations behind the content. Thank you for joining us for today's episode of Clinicians Brief the Podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a Vetmedics production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.